through vagal signaling, afferent and efferent, direct stimulation of the enteric nervous system, and via direct effects on the CNS by crossing the blood-brain barrier. Now, ghrelin itself, we don't give, but there were a number of studies done with ghrelin agonists. Michael Camilleri is one of the gurus of gastroparesis. He's done a lot of work on ghrelin and its agonists. One of the things we are here to talk about today is Relamorelin. And a large multi-center industry-sponsored study showed that it helped in especially one symptom, vomiting. In the clinical trial, it also significantly accelerated gastric emptying and decreased vomiting. Further studies were also done after that. Now, what is Relamorelin? It's a small synthetic pentapeptide. It's a selective agonist of ghrelin receptor that speeds gastric emptying in diabetes. It is similar to native ghrelin, but has enhanced plasma presence, and its circulating half-life is about 4.5 hours. So you at least need a BID dosing with it. It's a more potent prokinetic than ghrelin. And its elimination is mixed, some in the urine, mostly in the bile, and it does not cross the blood-brain barrier. Now, the phase 2 study for Relamorelin was done, published in 2017, 12-week phase 2b study with 393 patients. And in moderate to severe diabetic gastroparesis, it significantly reduced core symptoms and improved overall composite diabetic gastroparesis symptom score, accelerated gastric emptying, and was generally safe and well tolerated. So that brings us to our phase 3 pledge trial to evaluate the safety and efficacy of Relamorelin in patients with diabetic gastroparesis. The objectives of this study: compare the efficacy of Relamorelin with placebo in terms of severity scores of symptoms, pain, postprandial fullness, bloating. Compare the efficacy of Relamorelin with placebo in terms of vomiting frequency. Compare the safety of Relamorelin with placebo in terms of ability to maintain glycemic control, frequency of major cardiovascular events, standard safety assessments, and also assess the safety of continuing treatments in patients who've previously completed the study. Inclusion criteria, and I am going to email the inclusion and exclusion criteria to Emily, so she can forward that to everyone, so everyone has an idea of who can be included in this study. Male and female aged more than 18 years, type 1 or type 2 diabetes more than 5 years duration, with controlled and stable blood glucose levels, with no history of episodes of DKA or the hyperosmolar hyperglycemic non-ketotic syndrome, within 6 months preceding screening, recent hemoglobin A1C equal to or less than 11%. But symptom-wise, patients have to have 2 or more vomiting episodes during the 2 weeks prior to screening, absence of an obstructing lesion, either on a scope or upper GI series, and the sponsor will obviously cover the cost, after the appearance of symptoms that led to the diagnosis of diabetic gastroparesis, and a documented delayed gastric emptying, and that will be done once the patient gets in the study. What are the exclusion criteria? A lot more than inclusion. So the patient should not have had a diagnosis of irritable bowel syndrome or small intestinal bacterial overgrowth, should not have a diagnosis of any eating disorders, intestinal malabsorption, any of the functional disorders like belching disorders or the nausea vomiting disorders we talked about, like the cyclic vomiting syndrome, history of any COPD or pulmonary disorders that can cause CO2 retention, history of gastric or duodenal ulcer within 3 months of screening, evidence of increased liver enzymes more than 3 times upper limit of normal, a diagnosis of functional dyspepsia before the diagnosis of diabetes. Patients should not be on GLP-1 analogs, should not have had a pyloric Botox in the last 6 months, should not have had gastric surgeries like we talked about, fundoplications or gastrectomies or gastric pacemakers, etc., or bariatric surgeries. shouldn't be taking opioids, obviously, shouldn't be receiving tube feeds, or have had a history of malignancy in the last 3 years, or should not be allergic to any of the components of that that breath test, like egg, wheat, milk, etc. Should have a GFR of less than, should not have had GFR of less than 30, or should not have a prolonged Curie interval or some EKG abnormalities that we will figure out later. Now with this, I hand you over to the wonderful Tracy Yang, who was the research coordinator for this study. And she's going to talk about all the different studies we have and her role and how to contact us.
Thank you, Dr. Gayam, for having me today. And this is the diagram of the study design. So if you look at the slides, and we have actually O1 and O2, but those two are identical. And our site has only O1, and that is 12 weeks treatment period and placebo controlled. And the purpose for this study is for safety and efficacy. So once the patient, they meet all the criteria, they might have options roll over from O1 to either O3 or O4, depends on the severity of their e-diary score. So if they go into the O3, they carry the same IP. If they get randomized as placebo at the very beginning from O1, they will stay as placebo for the O3, but otherwise, if they randomize at the O1 stage, they will carry on the active IP for the O3 as well, and the same to the O4. The only differences between O3 and O4 is if initially the patient, if they did not meet all the criteria of O1s, they might be able to enroll and then starting from O4. So, and also O3, that is 40-week treatment period followed by 6 weeks randomized with withdrawal period. So the purpose for that is to say, if there's any, efficacy or, if we discontinuing, especially the active treatment. So if the symptoms might, reverse. So I think that's the purpose. For the O4, it's 52 weeks treatment. And like I mentioned earlier, and then if the patient didn't qualify initially to participate in O1, for example, if their vomiting episode is not enough to qualify O1, they might be able to qualify from O4. So, and also there's actually upcoming O5 study, which is going to be open label. So, but it's not on this slide. And this is my contact. I'm one of the study coordinators and research nurses at the CTSI, and our function is teaming up with a wonderful team like Dr. Gayam, all the PIs and sub-Is, and then we work with Ruby Labs, and then pharmacist Lisa Giblings and her team, and we work closely with clinical nurses, schedulers, as an on-site team. And our site team will work together with many others, like, monitors, sponsors, CRA, and we have wonderful team at the CTSI as well. The duty that I do, or coordinator we do, is, make sure, protocol compliant with good clinical practice, ICH, and regulatory agencies such as FDA, and then we do a lot of clinical trials communications. Like I mentioned, this is all team working. At the same time, we protect the subject, human subject safety. At the same time, we like to, help with advanced medicine as well. And informed consent process that is ongoing process, and we have to make sure patients fully understand the purpose of the clinical trials, and also we make sure they're safe. And as coordinator, we help the PI, we follow up the subjects, the participants closely, and we make sure to capture all the AEs or SAEs or, and follow up and schedule all the visits as well. Documentation, we spend a lot of time working on the source and make sure the integrity of the source data is everything. Patient recruitment, we have different methods, and we a lot of time we pre-screen, a potential patient at a clinic, and sometimes Spencer have vendors like this one. They use a Curium, so the patient actually they research somewhere, and they'll find the survey, and they will reach out to us that way. So, and ethical issues, I mean, again, the goal is to protect, the human subject rights and the well-being at the same time when we are conducting the trials. Financial, and working with our accountants closely, and sometimes we pay the patient with a little stipend and gas mileage reimbursement and personal development. And then that is, we have ACRP certification or SOCRO, and that is more like, keep up with the clinical research as a coordinators, in that aspect. So right now, this clinical trials is globally screening on hold right now due to COVID, but it might be open at any time. So if you happen to have a patient that might need our help, if there's no any other options, and here's my contact, you can see my email, and you can always drop e-numbers through the Epic step message and copy me and Dr. IM, and I'm more than happy to look into the details for any potential patients and that might need help with us. So thank you very much. Back to Dr. Gaia.
Thank you all for joining us for this grand rounds. And I would really urge all of you to look out for these diabetic gastroparesis patients who could be a part of our clinical trial. Thank you very much.